Welcome to this week's episode of Morning Report Emergency Medicine. I'm Alec Weir. This is the case of the all-seeing eye, or should I say, the none-seeing eye.
Under pressure.
An 89-year-old female with a past medical history of hypertension and bilateral cataracts presents with headache and nausea for 2 days. The headache's located on the right side of her head. She doesn't report any vision changes when I ask, but the daughter states that she was admitted last week for blood in the brain. This story gets weirder and weirder. Her vitals are temperature of 36.4, heart rate of 74 beats per minute, blood pressure of 158/56, breathing 17 times a minute, setting 100% on room air. What's her differential diagnosis? Let's break it down. First year style. Primary headaches, right? Tension headaches, migraine headaches, cluster headaches. We're always worried about those secondary headaches. Intracranial hemorrhage, meningitis, temporal arteritis, cerebral venous sinus thromboses, or vascular dissections, either carotid or vertebral. What else? Anything outside the brain? What about carbon monoxide poisoning, high altitude headaches, odontogenic headaches, dental pain, dental abscesses, and then acute angle closure glaucoma? And this is our patient's eye. You can see she has a red injected conjunctiva. She has a large, fixed, dilated pupil. You can see this gray rim on the outside. This is her cataract. But she has a large, fixed, dilated pupil. And this is the first time I've ever noticed this. When I touched this patient's eye, it felt firm. Her pupil on the right is 6 millimeters compared to 3 on the left. The conjunctiva is injected like you saw. Vision is to movement only on that right side. But she's 20/40 on the left. I again ask her about vision changes, and she tells me, well, my vision's always bad. And then that her intraocular pressures is unreadable on that right side, 18 on the left. Now remember, if you get an unreadable pressure with your Tono pen, it does not mean that the device is broken. It has a limit. It's just like when you check a sugar and it's RR high, you can get an unreadable pressure when it's too high for your instruments. This is acute closed angle glaucoma. You have a red eye with a fixed mid-dilated pupil like we had in this case. You have a shallow anterior chamber if you look at it under the slit lamp, and then increased intraocular pressure. These patients have congenital narrowing of their anterior chamber angle that closes under certain conditions. It's usually sudden onset eye pain with radiation, and that radiation can have patients thinking this is a headache. And classically, this happens when entering low light. Every test question I've seen is always a movie theater. Always a movie theater. How do we treat it? Well, we have to address the problem, and a lot of these are with eye drops or with ocular medications. First is a beta blocker. Timolol is what we have at our shop. This decreases fluid production within the eye. And then you also want to give, if you're giving a beta blocker, you want to give an alpha agonist, and we have brimonidine. This also decreases fluid production and increases the drainage. You want to give a carbonic anhydrase inhibitor like acetazolamide, because this also decreases fluid production. And now the recommendations are, if the vision's really bad, like in our case, movement only, it should be done IV, or you can get away with PO. And then, this is an ophthalmologic emergency. What are our take-home points? Remember acute angle glaucoma and your headache and nausea vomiting differential? This will be a painful vision loss. Our ocular findings are decreased vision, pain, that fixed mid-dilated pupil, and then increased intraocular pressure. Your treatments are your beta blocker eye drops, your alpha agonist eye drops, and then your systemic carbonic anhydrase inhibitors. And of course, getting ophthalmology involved. You can follow me on Twitter at Weir_Alec, or subscribe to this channel for more updates from Morning Report Emergency Medicine. And as always, keep your eyes out for those interesting cases.